Derrick, thank you very much for joining us today, and really excited to have a chat to you about a bit about your background and some of the challenges that you're seeing in the space of AI in health, digital tech in general, and the work that you're doing.
So my name is Derrick. I'm a clinical oncology doctor. I work in the Beatson Cancer up in Glasgow, Scotland. But I also run this organization called Adopt Doc, where we connect healthcare companies with healthcare professionals. We started about 2 years ago, worked with over 162 startups, really just speaking to lots and lots of founders every single week to really help them understand what the NHS is about, what healthcare is about, what the clinical perspective or how the boots on the ground will perceive a single technology. And we have also spin out from another company called the Medical Consulting Group, where we actually deliver focus groups, engagement sessions for healthcare companies, helping them map out the clinical pathway and the commercial pathway of how you should penetrate the UK market for healthcare. And that's been going quite well as well. And we are just planning a full rebrand this year. So all things being well.
And it's very exciting. I think it's part of the reason I was so interested to talk to you is because this is a really important and hot topic of conversation as well around getting doctors or people who have experience in clinical settings involved in startups or digital health innovation.
Of course.
So what would you say are some of the biggest challenges that you see from people that you work with in integrating digital technology into...
So from a clinician point of view, now say 95% of the founders we work with are technical founders. So founders, they come from an AI background, they come from a very strong programming background, or they come from a very commercial background. So most of the people I speak to are non-clinical in nature. And they often build up teams. They often are like repeat founders. They built something before. They want to go into healthcare, motivated by a purpose, motivated by a personal experience from either themselves or their loved ones. But one of the biggest challenge I see is that a lot of founders are directionally correct in the way they think and they approach the problem space. But when it comes to the nitty-gritty details, they start to fall apart. So we often see people build up tools that looks good. Sometimes they don't have a good UI, but when clinicians are playing with it, looking at it, they're like, I'm not too sure how I'm going to use this. I'm not too sure how is this going to fit into the clinical pathway, or I'm not even sure how is this going to solve a clinical problem. Very often, most technologies actually increase the workload rather than decrease the workload. And that is very true even for AI technologies. I'm sure you've had conversations with Hugh, you've had conversations with Liam. A lot of these technologies paradoxically actually increases the workload a lot before it will eventually reduce the workload. But there's this huge hump that we have to go through first, because there's so much learning, there's so much rejigging of the system pathways. It's all about creating new policies and stuff like that. And a lot of these things are very opaque from the outside, and a technical founder would just not understand these things. Just like I wouldn't understand how to code or how to create an AI algorithm, I'll be absolutely hopeless in that. So the whole passion really of doing what we do is try to bring these two worlds together and to really try to do something good together, because we know from there's this huge EU paper that came out in 2021 or 2022 that says that 87% of AI algorithms in healthcare never leave the academic setting, and that's a very common number we hear all the time, because all of them they create it, they test it on a properly curated data set in a very artificial academic setting. They publish the paper saying, oh, wow, this is great performance, and it never goes on to serve anyone or any patients anymore. And one of the biggest problems that they've quoted, one of the greatest challenge they quoted is there's very little stakeholder engagement. They don't really speak to the people on the ground on how would this actually be used to streamline our workflow. They've not spoken to the nurses, they've not spoken to the pharmacists, they've not spoken to the doctors. And that really leads to a problem of a mismatch between what people build and what people actually need. And trust me, healthcare really needs a lot of technology. That's why I do what I do.
Yeah, and why do you... And I think that's a really important thing to be doing, because, like I said, it's a hot topic of conversation. But why do you think their founders aren't engaging so much with the stakeholders that they're going to be working with? Because from an outside perspective, people might think that seems like an obvious thing to do.
So that's a very good question, and there are barriers. There are real barriers, I remember speaking to a founder who came off the Antler program and, already raised money already. They have money, they are a proper company, and they will look searching high and low for 3 to 4 months, engaging with all kinds of NHS bodies. And when I spoke to them for the first time, they're like, "You're the first doctor who spoke to me in 3 months to 4 months time," And it was really, really sad to hear that. There are real barriers in place, and that's what our whole company does, is we really try to reduce that barriers. The first one is clinicians and technical founders, they don't speak the same language. So a founder may be very excited to talk about, oh, look at my performance of my algorithm, look at the AUROC of my performance, oh, we perform better than GPT-4 or GPT-4o. And then the clinician will be like, I don't even know what those words mean. How does this thing work again? And that was an actual conversation I had with a physicist, And so this mismatch of language happens a lot. The second thing is problem to do with trust. A clinician is so busy, and often the perception is that someone from the outside is not very credible and don't know who you are. I'm already knees deep in my work. I don't really want to take my time up to speak to you unless I know who you are or what can I be trusted or not. So that's the second barrier. And the third barrier is quite a very practical barrier, is that clinicians don't want to work for free. They've already been working so hard and so long already, and while these startup founders, they are very keen to engage. They are very keen to engage, but they often kind of expect clinicians to give up hours and hours and hours of their time for free. And we sometimes have to draw a line somewhere where an hour chat, sometimes that's fine. If the clinician finds a lot of alignment, finds a lot of purpose, and wants to be of help, an hour's chat, no problem. The problem then comes when the founders start to say to the clinician, "Hey, do you mind sitting on my board? Do you mind giving me a day of your time every week or every month? Can I put your name and your title on my webpage? Can I raise with you as my advisor?" And they don't realize that that's putting a lot of liability on the clinician. It's putting a lot of liability on the clinician, and the clinician will not be comfortable doing that. So putting all this together, you get this environment where the founders really do want to speak to the clinicians, and the clinicians do want to speak to founders as well. But they want to speak to someone that they can trust, and someone that someone is not going to really screw them over, to be very honest.
Yeah.
And that's why we come in, we speak to the founders, we try to understand what their problems is, understand the clinical profile that they need, speak to the clinician, tell them about this company, and we serve as the middle ground. We provide indemnity for the clinician, so covering him from an insurance point of view, and then we also and do the whole scheduling, contracting, payment, and everything. And that really, all the clinician needs to do is just turn up, have the call, and then get paid and go back home. So that's we need to break the barriers down so much to that point. And obviously, in a cost-effective way for startup founders, we can't be charging them thousands and thousands of pounds. We have to do that in a reasonable way.
It's interesting what you say about clinicians being so busy, and that's abundantly obvious that they are so busy. I guess my question is, how do you also pick between the noise of people who are going to drive more meaningful impact on the ground or people who aren't, essentially?
Yeah. And that comes with experience. That really comes with experience. When I first started off doing this about 2 years ago, I was taking calls with everyone, and there will be time wasters. There are gonna be people who will waste your time and who are really out for themselves and who are actually building things that they want to build themselves, and they're just completely gonna shut out whatever feedback you give them.
Yeah.
And those companies don't exist anymore, by the way. I'm very happy to say. There are people who are genuine, and most of them are. All right, I'll say 80% to 70% of them they are genuine. They really want to learn. They really want to build something, and they really bet their time, their energy, their effort. They quit their jobs. They've set up this company, and they want to go all in on this. The few telltale signs I get when I just even speak to them on LinkedIn, a few messages, is first of all I gather their attitudes and perception towards regulations. Do they take regulations, data protection, do they take cybersecurity, do they take these things seriously, or do they just say, oh, that doesn't apply to us, I don't really care about it, that's not our problem, we're not going to do this? If the moment they start to have that, then it kind of tells you that, oh, you don't really understand what are the legal ramifications that your product has to go to market as well. And it also tells me that you are not very serious as a founder, because if you're truly serious, you will have left no stone unturned, and everything's online now these days. You can get it for free.
Yeah.
You know, Hardin Health has a fantastic website. You can just
Yeah.
go through it, and no one, and I create so much carousels and so much very very easy to access and understand topics. And so first point, do they take cybersecurity? Do they take data protection? Do they take patient safety seriously? And the second thing is we have a conversation on how open to feedback they are, how open to having a conversation they are. Some founders, they come across as very bitter and very, this is my way, this is how it must be done, I've experienced it this way, therefore it must be correct, and you guys are wrong, I am right. You know, I've seen that before as well, quite a few times. That doesn't work very well. That doesn't work very well, because that's not how you do a business. The way you do things is you take feedback from the people you're trying to serve, your clients, your customers, your patients, your clinicians, and you try to build something that really helps them, you know, and how open to the feedback and conversation that you have. And the third way I can tell is, you know, just are they looking to work with clinicians equitably? We're not asking founders to be spending hundreds and hundreds of pounds or thousands of pounds that they don't have, but I want to see, even as a test, do you value the clinician's time enough to, you know, reimburse them for their time? Because if you don't even value the time of a clinician, how can you go out and saying, oh, we're creating a product to save clinicians' time or to improve healthcare, when you don't even respect the people who will be using your tools? So these are the three ways I can tell just from conversing with someone at very early stage, and I can tell, okay, this is someone I will take a call with, this is someone I won't take a call with. You know?
I guess building on top of that as well, bringing AI into the equation, that's, again, something that I imagine founders will want to capitalize on, again, potentially with their own agendas, also sometimes genuinely, but thinking that they could apply AI to any problem that they can identify. What are your thoughts on integrating, you know, AI into these platforms as well? Because that not only introduces regulatory challenges, but also, you know, it's a very complicated thing to do.
Indeed it is. You know, one of the earliest conversations I've had was, so, you know, multimodal AI. Everyone's talking about it. Everyone loves it. Multimodal AI. You know, and for our audiences, it means like bringing together, let's say, I want to create an algorithm that can determine the risk of someone developing cancer, lung cancer or brain cancer, using data from the EHR, using data from the PAC system to get all the radiology images, to get the blood tests, to get their pathology images, to get everything, put it together in the algorithm, and the algorithm will churn out a risk score, you know. So that sounds great. Company actually raised money from that. But on the ground, they don't realize that data sits in different silos, and data are incredibly non-interoperable. Only a very few hospitals in the whole of UK, probably less than 10 or 20, actually have systems where you can actually plug and play an AI algorithm. Most of it, they are sitting in antiquated system. One's from EMIS, one's from View, one's from TrackCare, and it just doesn't fit at all. And you have to speak to try to get everything to come together. And just from that first step, you already failed and dead in the water, because there's no backend system to bring in all the data. And then which brings to the second problem is the output of this AI meaningful enough to make a clinical change or change my clinical practice?
Yeah.
No, we've spoken to a few companies that before they create an algorithm that, yes, does what it says on the tin. You know, it actually inputs if you clean up the data, you chuck it into the algorithm and it produces an output. It does what it says on the tin, it comes out with a score. But the way it does it was that it churns out a list of tasks for the clinical team to do every single Monday. And it brings up an extra 30 patients where you have to personally call one by one to invite them to do another test for them. And then and every Monday it churns out again and again and again. In an already resource-strapped clinical setting, it doesn't add a lot of benefit at all. For a very minuscule risk reduction, it adds like a crazy lot of workload. So that happens when you have a mismatch of understanding of the clinical pathway. You know, if you don't realize how people do their actual work and how people actually deliver care, then you realize that, yeah, I know that algorithm is not going to help anyone at all. And then the third thing, as we just come back to it again, is just the regulation bit. So many people, they say, oh, I'm going to revolutionize maternal health or female health. I'm going to revolutionize mental health. I'm going to create this algorithm that's going to be able to do this, and this. It's going to free up the workload of the clinicians. It's going to get patients better access, which are all wonderful things.
Yeah.
But those things tend to be falling directly into the medical device space, and that is a class 2A minimum device, which takes few million, 2 million, 2 years minimum, and they just don't understand that is the kind of game that they're playing from the start get-go. They're thinking that, oh, I'm just going to create an app, put it up an app store, and bada bing, bada boom, I'm Facebook. The truth is, the more with great responsibility comes with great power comes great responsibility, and if you want to do a lot, you have to play the big game of regulations, cybersecurity, data protection, NHS.
Yeah, and I think that the takeaway from that is that there are profound challenges to, again, not just getting a device or digital technology into the NHS, but getting something with AI is it's massively more complicated. And I think something that I've realised over certainly more recently is the infrastructure challenges as well. And you touched upon that briefly there about the interoperability within healthcare systems, and they're not often compatible with these tools that we're so interested in integrating. So you've touched a bit on some of the things that perhaps innovators can do from their side to improve how they work with the healthcare system, but what do you think the healthcare system can do itself?
So I think if healthcare system if the NHS is really serious about using AI, and we're talking about the actual hospital level, we need to have the what they call the 3 Ps, platform, policies, and the people. You need to invest in the right people, because AI algorithms are not apps, they're not software, they are complex, hunky, clunky, big tools, and there's AI drift, there's a single mismatch in the data can just completely wreck the entire algorithm. So you need to invest in the right people. You need to invest in data scientists. You need to invest in AI engineers. You need to invest in clinician scientists who will be able to carefully deploy and monitor this algorithms. You need the right platforms, things like Newton's tree, to be able to see how the algorithm is performing over a longer period of time. Is it actually doing what it says it does in that local setting compared to its initial production setting? And you need to have the policies in place. Who is responsible to monitor these things? Who is responsible to evaluate for mistakes? Who is responsible to execute the output of the AI? And governance is a huge issue. So people, platform, and policies is often missing. And the fourth one is obviously pounds. You need to have the money to actually to hire the right people, engage the right platforms, and write the right policies. But from the data infrastructure point of view as well, we need secure data environments, SDEs as they call. The most famous one we have right now in the UK is the one that's done between Roche and Gosh, Great Ormond Street Hospital, and they've created a really robust system. They created a very robust system to allow AIs to just come onto their system and actually deliver value immediately. And what they've built is literally just that, that infrastructure to allow algorithms to go on top of the infrastructure. They're not even building AI algorithms. They have built some, but the main purpose of the 5-year project was to build the whole infrastructure, And we need that. We need that middle layer to come in, gather all the data into the middle layer to allow algorithms to sit on top and actually extract data. And that's exactly what we need. We need AI needs data as the oil to power it forward. We hear these cliches so many times before. But as a clinician, I can see very much how data are really kept in silos. So if I run an oncology clinic, let's say the breast oncology clinic or the germ cell clinic, I have to open 4 softwares. Open 4 softwares to be able to check everything, make sure that everything is okay before I get a patient into my room. I need to check the clinical letters in the past. I need to check if their blood test been done properly. I need to check what's their previous scan results like. I need to check what the pathology results is like. I need to go through different systems just to put together a picture of the patient. How are you going to do that at scale with millions of patients in NHS trust? It's impossible.
And it's different across institutions as well. Like the system that you have there, it could be completely different
Exactly.
in the next one. So it's
Exactly.
it's where do you even start?
And you know what's the worst thing? It's like, let's say Glasgow may use track care, and Edinburgh uses track care as well, but the versions are different. Like Edinburgh is getting the higher end version, and they have a lot more data there, and the Glasgow one is a little bit more belts and braces only. So it's like, it's an impossible game. It's an impossible game to play, and I think I think that a lot of people don't really understand that, and until we roll back the hype and understand, oh, this is what we actually need.
Yeah.
That's only when AI will really kick off.
I think that's a good point to focus on as well, is the hype and whether it's being almost forced, like almost jammed down the throat of the NHS, so to say. The AI, if it's not ready, and again, these sort of siloed implementations of AI at different trusts or different. There are some wider reaching projects which I think are really interesting. But do you think perhaps that resources are being wasted?
Well, to be very fair to the NHS, to be very fair to the innovators here, there has been a lot of great progress. There has been a lot of great progress, particularly in the radiology space. No one can say that the radiology AI is not being pushed forward. There are some very good initiatives, very very good research, very very good operational stuff coming up. So you really can't fault the NHS for doing that. I think we are being pushed forward by the hype. There's lots of ways, but the general direction is definitely forward. It's definitely forward. I mean, and the UK, we have to really understand it on the global stage, really is a leader in many many ways. Because the USA obviously is USA. It's a lot more bigger. They have a lot more money. That's fine. But compared to the rest of the world, there are 200 over countries in the world. The UK really sits quite in front. They have the AI fund. They have the policies, the AI Act. They have the sandbox as well. So the UK is pushing AI forward as a very strong agenda compared to the rest of the country. So we shouldn't take this as the NHS is doing poorly. The UK is not doing AI properly. No, because that is not true at all. The UK is doing it a lot better than a lot of countries in this world. Most countries that don't even have a plan. But obviously there's room for improvement, and I guess everyone is very impatient. Everyone wants to see AI now. I want to see AI now. And with more hype, everyone's just like, where's all the AI, But it takes time. It takes time to build up the infrastructure. And I guess it's because that hype that's brought us to this level, it gave us an awareness of where we are lacking from here to here. And that's when we start to realize, we need back to basics, build out the data infrastructure, build out the policies, hire the right people, get the right AI.
Another issue that comes from that as well is, like you said, the money. Like, where do the pounds come from? And I don't know if you have any thoughts on that.
So reimbursement is the biggest linchpin for every single health tech founder. You can get your regulations, you can get your clinical evidence, you can get your cybersecurity data protection, you get your clinician engagement, blah 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 blah. But if you don't get money from the NHS to pay for your product, you're screwed either way. You're a company. You're not a company. You're not a business at all. You're a research organization. The challenge that we see from the NHS right now is that we are very broke. The NHS is really really broke. We are so broke that we're not even hiring actual human staff. A lot of NHS trust has gone into special measures. They're doing a hiring freeze. If we can't even afford staff, and if we're cutting back on a lot of things, it's going to be very hard to justify purchasing a multi-million AI project that does only one thing.
Yeah.
And that's the nature of most AI tools right now. It serves a very narrow field. Like, I'm going to do lung cancer screening, I'm going to do breast cancer screening, and that's all I'm going to do. And the financial returns of this may not be as clear. You won't get it back in a year or two. It might be something that gets realized over 5 to 10 years. But ultimately, that's the kind of vision that we need to have to prioritize the long-term gains rather than short-term capital gains. But alas, in the NHS, their hair's on fire all the time, and you can't really blame them for just looking at the short-term short-term crises, because we are in a crisis.
And do you think there's a role for private institutions to play in this, not just for providing healthcare services, but for investment and partnering with the NHS?
100%. First of all, we know the NHS doesn't fund any clinical trials. Not usually, at the very least. Oftentimes, start funders, they have to either win a big grant from Innovate UK or win a bigger grant, or they have to raise VC money to run clinical trials. That's what most biotechs tend to do anyway. Biotechs, pharma, they raise external money to run clinical trials to prove that their project works, to go through regulations, and etc. etc. The private setting definitely is very important in the building and the success of these companies at the early stage. But ultimately, it's the procurement and the purchase that matters, because you still need paying customers. And the irony that we're starting to see more and more, and people are speaking out a lot about this, is that the UK seems to be a great place to build, but may not be a great place to sell. And I'm sure Harry heard this a lot of times, haven't you?
This is so interesting because someone brought this up, and it really sort of stuck with me, this idea, and they were saying that the UK is a great place, literally as you said, it's a great place for people to build these products and these ideas, and then they go over to the US to sell them, and only then can they sort of have enough money to be able to come back into the UK ecosystem. And I think it's a really interesting dynamic.
Yeah, and I think it's all... I'm sure someone more clever than I who runs economics and procurement in the NHS will be able to answer this. But I think the financial incentives don't quite align sometimes. And, well, we also just don't have enough money. I think that's really the problem. We just don't have enough money in the system. And if you see the balance sheets of United Healthcare or Kaiser Permanente, you realize that they operate at a much larger scale. We're talking about 10 times, 100 times larger than whatever NHS Trust is playing. They're larger than Disney, they're larger than Marvel, and those people, they have the money to buy, they have the money to try, they have a lot more flexibility to do these kind of things. Whereas the NHS, we have always about value. We need to get nice approval, we need to get signed approval before we actually purchase anything. And that's because we are so price conscious, because we have less money. That's the obvious answer to that.
And AI is expensive as well. It's like, why would you the value proposition for spending hundreds of thousands or millions on AI infrastructure for maybe a more specific use case, when that could be used to buy new scanners or to
or you hire more GPs, or hire more nurses, or hire more doctors who can just deliver like 10 times more than an AI currently is. So I guess we're still very early, isn't it? We're still very, very early. The AI's some great stuff coming up, some great stuff that are really, really, really good, who can do like a specific role like much better than a human can do, and they can do it much faster as well.
Yeah.
But by and large, the value proposition is not quite as clear. I think Hugh actually mentioned something before. I think he did like a big financial economic study for a client of his, and it actually shows that AI actually gave a negative return rather than a positive return. Yeah, you can probably reach out to him to see if he'll share you the presentation. I remember seeing him posting on LinkedIn about that, and I'm not really surprised. I'm not really surprised because it's a pricey stuff, and maybe that's why we don't have much AI funds coming out anymore. We used to have like a few rounds of AI, NHS AI fund. Now these days we're not hearing much about that anymore.
Yeah. No, that is interesting. I was also going to ask you about lessons learned from, so I'm sure you're aware of Skin Analytics, and they actually get their Class 3 certification. So what lessons, and that's obviously more or less, they are working with, I believe they're working with hospitals, but also, they're a private company. So what lessons do you think that there are to learn from that? Because I think that's quite an exciting, hopeful thing to focus on.
Yeah, and I think people have to realize that Skin Analytics is not a new kid on the block. Skin Analytics have, I think, been there for almost 10 years. They have been operating for a very long time. They're not just someone who just came in over the past year or two and then just bam, bada bing, bada boom.
Yeah.
But what we've seen in Skin Analytics is They, first of all, they serve a real problem. They serve a real problem. They serve skin cancer is an issue. They have very good engagement from the start. They work with dermatologists all the time. They took their regulations seriously, and they just done things very rigorously. They played the game properly as it should be played, and they succeeded. But more importantly, they survived. They survived for a long period of time. It's not something that's done in a year or two. It's something that's done over many years, and I think that's the lesson that has to be learned. This game is a very long game. No one comes in and cashes out in like 5 years. It's something that takes time,
especially with the NHS.
Especially with the NHS, and we know that skin analytics have raised good money, but they've been supported by the NHS since 2016. It's 2025 now. It's very tempting to feel that 2016 is just 4 years ago.
Yeah,
it's 2025 now. So they've been in this game for a long time, way before AI hype has been there. But yes, they survived long. They partnered with the NHS. They raised money. They took their regulations seriously, and now they're the first and only Class 3 AI device in Europe, if not the world.
Yeah, and do you find that something quite an exciting achievement?
100%. Max, it's like big. It's a huge achievement, because then being Class 3 means you can be used at the highest level, at the highest level, and it gives a lot more confidence to a lot more people that these things can be done properly. It's a shining beacon of hope, and it has to be shouted out from the rooftop so that other founders will follow in their footsteps.
Yeah, absolutely. And I guess that leads me on to asking a bit more about your field of expertise in cancer and oncology.
So I'm a clinical oncology registrar, so working in the beats and going through the training right now, and things are progressing very fast in oncology, and this is nothing to do with AI or health tech or anything. It's just that there's a lot of interest in this space, rightfully so, because cancer is a devastating disease. A lot of money has been put into cancer, and we see breakneck progress in the drugs that's being made, in the outcomes that's being done for patients, because there's just so much interest. Globally, everyone is doing lots of studies, lots of clinical trials, thousands and thousands of trials, developing new drugs, and it's funny because we rotate through a particular tumor group every 2 years, and like a tumor group for breast cancer, 2 years ago. Things were very advanced already, and I came back to it again 2 years later, and it's just like new protocols, new drugs, new outcomes. So that's really exciting to see. It's a really good field to work in. Do we see a lot of tech and AI in oncology? More in not in the direct clinical space that we can see, more in the radiotherapy planning phase, more in the drug discovery space, less so in the direct day-to-day clinical use. But a lot of people like Pharos AI, very interested in like pulling out the big data to find like particular markers, particular patterns and stuff like that. So still an area of improvement, but a lot of what oncology is being driven by is actually still humans caring for humans, because cancer is a very emotive subject, and you still need people to handhold sometimes. You still need people to go through the whole process of getting a diagnosis and also getting a treatment.
I'm really glad I asked about your day-to-day work, because I think that's quite amazing to hear that you feel like it's making progress.
Still a lot of room for improvement. Don't get me wrong. I think, but we are in such a better space now compared to, let's say, 10 years ago, or even just 5 years ago. We have a lot more access to different tools, different drugs, different planning modalities from radiotherapy point of view. We have so much better understanding and insights, and it will only continue to improve and increase. So within 5 years time, 10 years time, the oncology care is going to look very, very different. So yeah, I'm looking forward to that.
Yeah, and I think there's some really exciting innovations going on in this space as well. There's work being done to do 0.5 Tesla MRI scanners, which are so compact, and they basically would be using like AI to more intelligently reconstruct the images. And there's technologies like that which could be game changers for having, more portable scanners in clinics and things like that. But yeah, I think the development of technology itself is very exciting. But there's also, on that same subject, there's lessons to be learned.
Yeah, it's a bit of a missed high five situation, and everybody is being very cautious and risk adverse, rightfully so sometimes as well. And I think data is going to be the big challenge, isn't it? We see lots of white papers on white papers, people touting, interoperability, we need to do data this, data that. But, on the ground, on reality, it's very different. It's very, very different. The information governance team, they're like, oh, is this right? Do we need to do this? Do we need to do that? And, I would highly recommend reading through the Roche paper. I've created a carousel on this as well, on the actual challenges they had building their data infrastructures. And it's really, really funny because it's like one of the challenges they listed out, and Roche did this for free with the NHS in Gosh. They say you've got to set up those whole data infrastructure, and they're not going to take any money out of it, or the whatever intellectual property is created belongs to Gosh. It's almost very unilateral in the delivery given. And despite that, there's still huge challenges like, setting up, getting the legal team involved. They need to hire a specific legal team, and Gosh needed to hire a specific legal team to hash things out, make sure that everything's okay before they start the work. And then they only realize, number one, the staff there can only use laptops provided by the NHS. And the laptops were like not great laptops, and it was crashing. It took like a day to compile certain data, and it just crashed. And they're like, what? And they wouldn't even let them use like external things like Docker, and they really can't even download any of these external tools that are used all the time, the GitHub and stuff like that. They can't even use it because it's against NHS policy. And they're just like, what? I can't build using the most basic of tools. So they have to actually purchase a high-end computer to put into Gosh so that they can use it in a local server. And it's wild. Yeah. There's just some stuff like, they need to actually get special contracts for the people from Roche to be able to work in Gosh, get them name tags and stuff like that. And that's the reality, that's the actual reality on the ground that people need to know. And that's the most passionate thing that I have, is to get all these people to speak to the right people. Because if you don't speak to the people that's actually on the ground, you're gonna be in for a rude awakening. You're gonna raise that 500K, you're gonna raise that 1 million or 2 million with a sweet pitch deck and with a great narrative, and then you reach to your first hospital site, and you're like, oh shit.
Yeah.
How am I gonna answer to my investors about how crazy this thing is? And it sets you up to fail if you don't understand these things early on.
Yeah. And do you think from your perspective there are any lessons to be learned from other innovation ecosystems?
I think there are a few things to learn from and to look at, and I think that we probably have to. I don't want to cherry pick anything, and I think we need to learn from the good things and not the bad things as well.
Yeah.
So, okay, how does a vendor, an AI vendor or any vendor of any health tech solution, how do they sell to the NHS? There isn't really a single platform for you to sell to the whole of the NHS. So you have to sell ICB by ICB. You have to approach all 44 ICB one by one to sell to them. And if you sell to one ICB, you've sold to one ICB. You need to sell to another ICB. You start the whole process again. They're trying to streamline things with the NHS marketplace, etc., and the NHS supply chain, etc. But there's the reality on the ground is they are still serving as door-to-door salesmen. They're still selling one place to one place. Now we take Germany for example. Germany has something called DIGA, and it's a single marketplace for clinical apps, clinical health tech solution. So if you pass their very, very stringent criteria, you get put onto DIGA system. The national insurance will pay for it. So if someone prescribes it, the NHS equivalent will pay for it. So people can reimburse it, and that's whole Germany wide. We need a single marketplace, and we need for someone to, if they do the hard work, if they've done the regulations, they've done the evidence, they get nice approval, they need to, then that means they should automatically go onto a system where people can just buy from it, and the NHS will pay for it. Much like what drugs are like right now.
Yeah.
A drug, let's say chemo drug. If it gets nice approval, then we'll pay for it.
Yeah.
And it's the same for Glasgow, it's same for Edinburgh, it's same for London, it's same for Manchester. We need something like that, because that would then financially incentivize these founders to do something. And we know financial incentive is the greatest incentive of all. Financial incentive is the greatest incentive of all, and that will then push innovation. So it will super turbocharge innovation. And I think the other things to really learn about is data availability, although I wouldn't say any one particular one has particularly cracked that just yet. Like having easy access to data in an equitable way that doesn't quite violate any human rights. China and the way they do things is certainly not something that's applicable to the way we do things here in the Western countries. So that's a lot to be said about that. But I think that's pretty much where I'll stop for now, because there are great examples to learn from overseas as well. There are great international collaboration. The Future AI framework is the most recent one that's just been dropped in January. That really brings together like how should things be done from an AI point of view. How should AI developers build trustworthy AI for healthcare? So that's an international gold standard guide for trustworthy AI, and I think that's probably what I would always direct AI developers to look at before starting the whole project, because that they need to understand this is what it takes to really build something that's trustworthy.
That's really interesting, and that again leads on quite nicely to education. Where does education sit into all of this? I guess you did just talk about the AI framework, but to what extent do you think healthcare professionals should have an understanding of these tools?
I think education can only be a good thing. And it's the reason why I create so much content on LinkedIn. And one of the things I've not really touched about is the whole work that I do on LinkedIn. I create lots and lots of carousels. I create lots and lots of. I think I've just done one on the Future AI framework as well. I've done a lot on DTAC, cybersecurity, data protection, etc., etc. And we have to go to where the people are. My passion actually comes in educating health tech founders, because I need them to understand these are the things that they must know, they need to know if they want to play this game of healthcare innovation. And sometimes, yes, it's good for you to create a big academic paper, that's really good, very well written, but only will be read by healthcare professionals or very academic research scientists, but will not be read by, let's say, a startup founder, because first of all, it's a 22-page document and written in quite heavy language sometimes, and yes, we need to find a way to create content that is easily accessible, nice to digest, in a way that they can understand. So that's why I create beautiful looking carousels, so that people can just read through it, whet their appetite, and if they're interested, they can go deeper into reading the papers and stuff. And that's why I create lots and lots of carousels. That's how I grew so quickly on LinkedIn as well, because people realize that, oh yes, what you've written is actually what I need to know, but I just don't have the time to read through 5 pages on the NHS website. I need to get a great overview of it first, and then find the expert to do it for me. But that's the thing. We have to go to where people are, and where AI developers are, where health tech people are. They're on LinkedIn. They're not on Twitter. They're not on Facebook. They're on LinkedIn, and we have to deliver the content here.
Yeah, and can you talk a little about your growth?
Well, just to take a segue, it's like so I started on LinkedIn 2 years ago. And it started with a random selfie, because I was so pissed. ChatGPT came out around that time, and everyone was so hyping it up. And I'm going back to my my clinical practice with pen and paper, and it's just like, oh, come on. And then the interface I was using to prescribe my chemotherapy, the interface I was using to do my patient records, they are like Windows XP interface. And I say like there's a huge mismatch between what is out there and what we can have. So I just do a selfie and say, hey, my name is Derrick. I'm a human being. Here's a picture to show that I'm a human being. If you're a health tech developer, if you're a health tech AI developer, and you need some robust clinical input, just reach out to me. No strings attached. And I had 0 followers then. I literally just started LinkedIn. That's it. And then it just started to grow. And I started to speak to I spoke to 6 people in the first month. Then it went to 6 people in 1 week. And then now these days we get 6 requests almost a day sometimes. And I speak to lots and lots of people. I try to understand what is it they're really struggling with, what are the questions that they're asking again and again and again, and I create content from that. I create content from that from what they asked me, they mentioned a specific point, they mentioned a specific perspective, and I started writing a lot more on that, and then just started naturally growing, sitting around 19K, close to 20K in just 2 years time. So that's really the aim of the game, is to really just add value to the ecosystem, in a way that they can digest, not in a big chunky manner that they just can't do this. And that's why I do a LinkedIn Lives as well. I did LinkedIn Lives, bringing in the experts on a particular topic, on a topic that I know founders want to know about. Just last Thursday I did one on patient engagement. How should companies engage patients?
I was having a quick look at that beforehand.
And it just got really surprising. 190 people eventually view it in that 1 hour that we started to do it. It's sometimes that's what you need. We need to bring people by the fireside to talk, to share their knowledge, to share their wisdom. We are an ecosystem, we are a village. We need to work together, and it's hard times. It's hard times indeed. So we have to come together. There are people that takes in a very old school way of, I'm a competitor. I'm going to do better than you. I'm going to go faster than you. I'm going to scale better than you. And people don't feed off that energy very nicely. It comes across in the way you write. It comes across in the way you speak to people. It comes across in your reputation as well. And you can't hide these things. These things will travel fast. And as you said, we're going to focus on the people we're trying to help, and just focus on that and that only. And that's how you grow naturally. When you start to think about the competitor, when you start to think about the giant problem, you lose your way. But if you just focus on the next person you're helping, the next person you're helping, the next person you're helping, that's how you go from strength to strength. All I did was focus on the next founder I need to speak to, the next founder I need to speak to, the next founder I need to speak to. And that's how it goes. And that's how you start to build out a business as well.
Yeah, no, that's very insightful. So how do you see the innovation space in Glasgow? In
Glasgow,
medical and AI?
Yeah, Glasgow is pretty hard going on it. Yeah, they're really, really serious about it. Of all cities, Glasgow really... So Glasgow currently has set up a digital health validation lab, and they're literally building like a 5-story building, like in the Queen Elizabeth campus. It's like they are properly going hard at it. And they're working with a lot of large AI companies in internationally, like Khor AI, with Canon, to really build like a big ecosystem. Glasgow is one of those places that actually still has some money to do this kind of work. And really they punch really above their belt weight class quite a lot. So we've just recently did like a panel talk in one of their like anniversaries, the 2nd year anniversary. Glasgow, watch this space. Glasgow has a lot to offer in this space, and they done what they call a triple helix, where the NHS works very closely with industry, works very closely with the University of Glasgow as well. So academia, NHS, industry works very, very closely together. It's one of a more unique ecosystem that's not really seen much outside of London as well. Like obviously big centers like Manchester obviously has a very strong system as well, but Glasgow is one of those that really they've invested a lot of time and a lot of money, into it.
Yeah. Another question I had, going back to a previous conversation about NHS and platforms. So because you were saying there's not like a unified platform or sort of, app store. I was thinking, where does Newton's Tree fit into that?
Harris obviously built up Newton's Tree, and to the people who have not heard about Newton's Tree, it is a platform to really help. It's like an app store for AI algorithms. It helps NHS trusts upload, deploy, evaluate, and monitor an AI algorithm safely throughout the whole process. Instead of taking like 11 months to set up an algorithm, their proposed platform is to, you can set one up, in a few weeks or days, and then you can just plug in, test it in a local setting, see if it works with the local setting. If it does, voila, you have a product that you can actually buy. If it doesn't work, then you can just scrap it, and that is the platform that he's trying to build. And I think that is really, really, really important, because the truth of the matter is that it takes a long time to set up a whole algorithm in a space like, Khor AI was being set up in Glasgow, and they're just a chest X-ray AI algorithm, and that takes months. And it takes dedicated teams to support this, and it takes probably hundreds of thousands of pounds to do it. We got to do it cheaper. We can't be spending 6 months, 10 people's time and hundreds of thousands of pounds just to set up one algorithm that does one thing. If that's what it takes, we will never succeed. Everyone will just give up. Everyone will just give up and the progress will just halt. So that's why the platforms are important.
Be interested to know what the sort of barriers are to bring
Money.
again money. Yeah.
Money. I mean,
Yeah.
the obvious one is money.
Yeah.
If you have enough money, anything and everything will happen. But you need money. I mean, Harris also, it was almost like, if you hear his story, I think he had a very good podcast episode with Annabelle Painter, the RSM Digital Health Podcast. If you hear the story, it kind of almost sounds like it was like right time, right place, right person.
Yeah.
The guys in St. Thomas had a bit of money, and then like Harris like managed to convince the board to like hire a couple of AI scientists. Some data scientists, and got some results, which prompted more funding, which prompted more results, which prompted more funding, and it actually grew from that. So right time, right place is rather than like, oh, it was a design, it was the NHS top board that purposely wanted to do this, So maybe that's why it's not replicated as much, because first of all, not enough money, next of all, not enough initiative and not enough expertise. Harris is N=1 kind of person in the whole of the UK. It's not like there's lots of Harrises sitting around, And I think that's why we need to almost take that knowledge from his brain and his experience and really like spread it to the ecosystem, and more people need to be like this.
I guess quite a typical final question is, what are you most excited about in the space of, in your space, I guess, whether it be innovation or oncology?
I think this has to be said for the entire ecosystem. I'm not too sure if you knew this, Harry. The past 2 years have been really terrible for digital health in terms of funding and stuff. It's been really, really, really hard. So in COVID times, funding was like, woohoo! Everyone was raising big money, big sums, crazy sums, ludicrous sums. And then the past 2 years, the time where I started, wow, funding just went back. Nobody's raising any money. There's no money, there's no flow, there's no deals being done. But we are starting to see a lot more return of activity now. You see Neko Health has raised like 260 million, Flow has raised another few hundred million, and Pharos has raised another 25 million, and we're starting to see more signs of life again. And I think that's actually a really healthy sign for the entire ecosystem. When there's a bit more money being injected into this ecosystem, there's a bit more initiative, more brilliant minds coming in. The fact that you exist, the fact that I exist, is also a good sign to come that people are finding this scene and domain worthwhile enough to innovate in. So that's what I'm actually most excited in. I'm hoping that this continues, and I'm hoping that we see better innovators come through. We see we learn from our mistakes, and we start to fund the right things, and we hope to see people with the right money funding the right initiatives, which will then move on to the right tools for patient.
Yeah,
that's what we're hoping to see. So I think that's the thing that's may sound a bit too money minded, but actually that's very important.
No, I wouldn't say it does sound money minded, and money is a really important thing in this area, and like you said, it's one of the greatest barriers to technology being implemented and healthcare moving forward as a whole. So I don't think it's certainly not money minded in the wrong way. And what do you think is the biggest thing that you would change, if you could, about the ecosystem at the moment that would help to drive stuff? What do you think? It would just be funding, or do you think?
I would personally like to make it easier. I mean, this is very personal. I would like to make it easier for health tech innovators to access the NHS, to access the right clinical stakeholders, and to just make life, their journey, a bit easier. It's really unnecessarily hard at the current moment, and that's scaring off a lot of innovators and causing a lot of people to fail. I would like to make it a bit easier, to increase the percentage of like 80 to 90% of health tech founders fail. I want to reduce that number by at least 10% or at least 20%, because we got to make it a bit easier to see better tools. Right now, it's just too difficult. And how are we going to do that? Well, the work we're doing with the medical consulting group, Adopt has made life a lot easier for a lot of founders. But we are hoping to to really make a better impact in the next few years to come.
Derrick, thank you very much for taking the time to chat to me today. I really appreciate it.
Oh, nice to see you, Harry.
Yep, no worries. Take care.
Bye-bye.
Bye.